please welcome to the next session. I would like to ask Daniel Musser, who is going to present a talk on how much should we evaluate patients with clinically idiopathic PVC and VT. So, Daniel.
Good afternoon. Good afternoon, everybody. Thank you for the invitation to this amazing meeting. So what I'm going to do with this presentation is, first of all, to define idiopathic ventricular arrhythmias, and then to show how and why we should evaluate patients presenting with apparently idiopathic ventricular arrhythmias. If we look at large population-based studies, we can see how they have consistently reported an increased risk of mortality, including an increased risk of sudden cardiac death, in patients presenting with frequent PVCs, even if they have a completely normal heart. But the problem with all of these studies relies on the definition of normal heart. Because if we look at the methods, it was done basically on the absence of history of structural heart disease, on a normal physical examination, and on a normal resting ECG. Only one study out of 19 included in those two meta-analyses actually used transthoracic echocardiography to rule out the presence of structural heart disease. But we know that the truly idiopathic ventricular arrhythmias are the ones that arise in the absence of structural heart disease, which is actually the major determinant of risk in these patients. And structural heart disease can usually be ruled out with routine diagnostic investigations, including 12-lead ECG, Holter monitoring, exercise stress test, and transthoracic echocardiography. But sometimes we need more advanced imaging techniques, including CT scan, CMR, or even FDG PET in selected patients. So, idiopathic ventricular arrhythmias usually have very typical characteristics. First of all, they arise from peculiar sites within the heart, which are represented in more than 70% of the cases by the outflow tracts. And for this reason, they have a typical QRS morphology. They are usually monomorphic, they are usually suppressed by exercise. So when we saw characteristics that are different from these ones, we may want to further investigate the patient to rule out the presence of an underlying structural heart disease that can be the cause of the ventricular arrhythmias. But we know that even in patients with a completely normal ECG and a completely normal echocardiography, if we use advanced imaging techniques such as CMR, we can find concealed structural abnormalities in about 10 to 15% of patients presenting with just PVCs, and in about 1/3 of patients presenting with any kind of ventricular arrhythmias, including sustained VT and VF. But what is even more important is that the structural abnormalities that we found with MRI have been repeatedly associated with an increased risk of sudden cardiac death during follow-up. This is a clinical case, is a 27-year-old patient presenting with very frequent PVCs, more than 30,000 on Holter monitoring. As you can see, he had two morphologies, both consistent with an origin from the outflow tract, and those were the most frequent PVCs. But he also had a third morphology of PVCs, consistent with an origin from the LV free wall. The first two morphologies were suppressed by exercise, and he had a normal ECG and a normal transthoracic echocardiography. It was 2008, and at that time we decided to perform an MRI. What we saw was just a small patchy area of fibrous fatty infiltration that we didn't know how to interpret. So at that time, with the knowledge that we have at that time, we thought this was maybe a previous myocarditis with fatty metaplasia. The patient underwent a successful PVC ablation from the outflow tract, and then we followed him over the years. But what happened during the next 10 years was that he started to develop, wait, sorry, I need to go back, here we go. He started to develop more and more PVCs with different morphologies. And at a certain point, he started also to have runs of non-sustained ventricular tachycardia. You have to think that during all of this time, the patient still had a completely normal echocardiogram and a completely normal ECG. So about 12 years after the initial presentation, we repeated the MRI, and as you can see, we saw a completely different scenario. Let's see if the video works. It's not. I don't know why it's not playing. Yeah, the video is not playing, but what I was going to show is that the LV was still normal in terms of dimension and ejection fraction, but now we have an extensive fibrous fatty replacement of the whole left ventricular wall, including the interventricular septum. We also performed an endomyocardial biopsy, which confirmed the presence of fibrofatty replacement, but also myocardial disarray. And we performed a genetic testing, which was positive for a pathogenic mutation of desmin. So our final diagnosis here was that of a left-dominant form of arrhythmogenic cardiomyopathy, and we decided to implant an ICD. And thanks God we did it, because after about 1 year, he had the appropriate shock for VF during exercise. On this basis, we may wonder if we always should perform an MRI in every patient presented with frequent PVCs, even if they have a normal echo and a normal ECG. The answer is probably no, because we have to remember that MRI has several limitations. It's time-consuming. It takes about 30 to 40 minutes to perform just a routine investigation. It's expensive. It's not widely available. It can be deeply affected by artifacts related to the presence of ventricular arrhythmias, but it also has a substantial lack of both sensitivity and specificity. In terms of specificity, if from one side MRI is 100% specific in identifying ischemic scar, when it comes to non-ischemic scar, which may be related to inflammation, mechanical stress, or a cardiomyopathic process, we may face several different patterns, all of them intramyocardial or subepicardial, but almost none of them specific for a peculiar disease. In terms of sensitivity, the capability of MRI to detect the presence of scar relies on the technique of late gadolinium enhancement, which relies on the different kinetics of the contrast agent between the healthy myocardium and the scar, with a slower wash-in and a slower wash-out in the scar compared to the healthy myocardium. So if we wait 10 to 20 minutes after the administration of gadolinium, we may reach the maximal difference in concentration of the contrast agent in the scar, which becomes visible as an area of hyperenhancement. But unfortunately, the capability of LG to detect the scar also relies on scar architecture, because it requires a critical amount of dense scar to be detected. As a matter of fact, in patients with diffuse interstitial fibrosis, for example, in patients with non-ischemic dilated cardiomyopathy, LG can completely miss the presence of scar, even if it is present in large amounts. Now we have some new MRI techniques, such as parametric mapping and in particular T1 mapping, which are able to detect even the presence of diffuse interstitial fibrosis and even without the use of contrast agent, because they rely on the different response of the scar tissue and the healthy myocardium to the magnetic field and the radiofrequency pulse. We know that the diffuse interstitial fibrosis detected by T1 mapping correlates with the unipolar voltage abnormality that we can detect on invasive electroanatomical mapping. And now we have also data showing how, in patients with frequent PVCs, the T1 mapping values increase accordingly with the PVC burden, becoming particularly high when the PVC burden is more than 20% per day. We have also demonstrated that T1 mapping is an independent predictor of LV dysfunction reversibility in PVC-induced cardiomyopathy. And it is on this basis that the most recent European Society of Cardiology guidelines have put a recommendation of class 2B for the PVC ablation, even in asymptomatic patients when the PVC burden is very high, higher than 20%. If we look at all the studies that have investigated the incremental diagnostic the utility of CMR in detecting concealed structural abnormalities in patients with apparent idiopathic ventricular arrhythmias, we can see how all of them have identified a small group of variables, a small group of predictors of structural abnormalities. Those predictors include some strong predictors, all related to the characteristics of ventricular arrhythmias, including exercise-induced ventricular arrhythmias with a right bundle branch block morphology, especially with the superior axis, and multifocal ventricular arrhythmias. And then we have some weaker predictors, including male gender, older age, and family history of cardiomyopathy or sudden cardiac death. So we can use those elements to identify those patients who really deserve to perform an MRI, even if they have a normal echocardiogram. But how should we interpret MRI results? It's not just the presence of scar that matters, but we have always also to look for some specific features of the scar. For example, now we know that there are certain scar patterns, such as the so-called ring-like scar pattern, which is characterized by a circumferential layer of fibrosis involving the LV, that are associated with a very high risk of sudden cardiac death compared to other scar patterns, regardless the underlying ejection fraction. And now we are also starting to understand why. If we look at those two very recent studies, we can see how patients presenting with this pattern have a pathogenic mutation of genes like desmoplakin, filamin C, lamin A in up to 70% of the cases. So every time we see this pattern, we have to think about a potential underlying genetic cardiomyopathy, which deserves proper risk stratification and eventually ICD implantation, even if the ejection fraction is completely normal. We have investigated the role of extensive family screening with genetic testing and the CMR in patients presenting with this scar pattern. And we have confirmed that in about half of the cases we can find pathogenic mutations. But what is interesting is that in about 50% of the family members, we can find the presence of LV scar. And what is even more interesting is that ventricular arrhythmias were present only in patients who also had evidence of scar. 1/3 of the patients developed malignant arrhythmic events during follow-up, but all the events were in patients not just with scar, but with a complete ring. So our hypothesis is that probably here we have a genetic background that together with some external elements such as exercise or inflammation leads to the formation of scar. And it's only after the formation of scar that we see ventricular arrhythmias. Then those same elements lead to the progression of scar towards the formation of the complete ring, which is associated with an increased risk of sudden cardiac death. Let's remember that MRI per se is probably not enough to define the risk of the patient, and now we have data coming from different groups that show us how programmed ventricular stimulation may be able to further refine the risk of these patients and help us to identify those who really deserve a prophylactic ICD implantation. To conclude, in patients presenting with frequent PVCs, we have always to perform some routine investigations. And when those routine investigations do not show any abnormality, we have to look for some features, clinical and arrhythmic features, that may be associated with an underlying concealed structural heart disease. And in those cases, it's probably better to perform an MRI. But even in patients who do not have those high-risk features, MRI can be helpful if they have a very high PVC burden in order to stratify the risk of PVC-induced cardiomyopathy. On the other side, of course, every time we find the presence of structural heart disease, we have to stratify the risk of the patients with other tools, including genetic testing, programmed ventricular stimulation, in order to find those patients that are truly at high risk and deserve ICD implantation. Thank you so much.
Thank you very much. You may stay if there are any questions, comments to your, yeah? Please wait for the microphone.
Thank you. Thank you very much for the excellent presentation. I just wonder, what is, so in those patients with structural abnormality with scars you detected, what would you expect the mechanism of ventricular arrhythmia or PVCs? So it would be automaticity, trigger activity, some couples of re-entry. And did you analyze the coupling intervals of those PVCs or some more information?
I didn't show some other data that we have because of the time, but the thing is this. We have another important point is to correlate the site of origin of ventricular arrhythmias with the presence of scar, because we have data showing that in patients with typical outflow tract ventricular arrhythmias, and if you do an MRI, you find scar, which is, for example, in the inferior lateral LV wall, because the patient has for hypertension. So that scar is completely aspecific, is not associated with an increased risk, and the mechanism of arrhythmias here is probably automaticity, and those are just common RVOT, outflow tract ventricular arrhythmias. So it has always to be correlated, like where is the site of origin of the arrhythmia? There is a correlation between the site of origin and the presence of scar, because in that case, probably the mechanism is re-entry, okay? And those patients have a higher risk. But even those patients, the question is how high is the risk? Because they may have just PVCs and never develop sustained VT. And here comes the data about programmed ventricular stimulation. For example, the Michigan group, Bogun, has like a lot of data showing that if in those patients where the site of origin of the arrhythmia correlates with the scar, you perform a programmed stimulation. Okay? If you induce sustained VT, those patients are very high risk, and so they may deserve an ICD, even if they have a normal ejection fraction. We actually have started to do the programmed ventricular stimulation in patients with ring-like scar. Okay? So if they have a mildly depressed ejection fraction, a pathogenic mutation, and ventricular arrhythmias, we go straight for the ICD. But when they have a completely normal ejection fraction, or the genetic testing is not positive for a pathogenic mutation, but for example for a VUS, let's say, we do the programmed stimulation and we implant if they have if we induce sustained VT. And I must say that so far we have a short follow-up, but it's working. Like the ones that are easily inducible are the ones at high risk. The problem is that I don't know what happens to the ones that are not inducible. Maybe you need to repeat it like after a few years, or who knows. Yeah.
Thank you. Thank you for your answer. And I would just ask the next speaker, who will be Marek Szramko from Prague, from IChem, who will talk about the role of ganglionic stellate blockade in management of electrical storm.
So good afternoon, my name is Marek Szramko and I'm from Department of Cardiology in IChem. This talk, as was said, is about anesthetic blockade of ganglion stellate, which is a simple bedside procedure that has been increasingly used in the management of electric storm. So firstly, just a quick review of anatomy and physiology. Stellate ganglion is a bundle of usually 3 nerve nodes that are located in the neck on the level of C7 to TH1, just anteriorly from the transverse processus of the vertebrae and lying on the fascia of the musculus longus colli. These nerve nodes have several known functions. They lead fibers ipsilaterally to the face, but also to the heart. One of the very well-known functions is afferent signaling of ischemic pain, but also conveying sympathetic activation of the heart. And it has been known for several decades that anesthetic blockage of this node, which is very easily accessible by a needle under ultrasound, can suppress the pain signaling, but also can suppress arrhythmias. Nevertheless, until 5 years ago, this procedure was used only very rarely to manage electric storm. And this is documented by a meta-analysis from 2017, which included 38 procedures, which were, however, collected over 40 years. It took 40 years to collect 38 procedures from 23 reports. It was mainly patients with acute MI and long QT syndrome. Only 16% of them underwent VT ablation. And most commonly, the anesthesia was done by bupivacaine. These authors showed a significant reduction of episodes of VTs and VFib and a decrease of ICD shocks. And this paper was really the one that brought this procedure into attention. And since then, it has been ever increasingly used in many centers. And this was also documented only 2 years later by the series reported from the Mayo Clinic. It was 30 patients with electric storm managed by stellate ganglion blockade. They were quite in severe condition. Almost half of them were on some kind of mechanical circulatory support. And these authors also showed that the procedure led to a decrease of the VT episodes by 92%. And half of the patients were free of any arrhythmia. What is important is that there was no major procedure related to this procedure. About half of the procedures were done unilaterally, half were done bilaterally, but there was no difference in regard to the outcome. Another series quickly after came from the Duke Heart Center. It was 20 patients with electric storms. Also, these patients were in quite severe condition, almost half of them on MCS. 30% underwent catheter ablation, and in this series, all the procedures were done bilaterally. They also did not see any major complication. There was only one minor temporary complication. They also reported a significant decrease of VT episodes and ICD shocks separately for following 24 hours to 48 hours after the procedure. And also almost half of the patients were free of any arrhythmias after the procedure. A very interesting paper came from our colleagues from the Třinec Hospital here in Czech Republic. They reported on 70 procedures performed in 59 patients who all of them had ICD. Therefore, it enabled precise calculation of all the VT episodes. And in this series, 30% of the patients underwent following VT ablation. They also did not observe any major complication, and they also reported a significant reduction of VT episodes, separately shocks, ATPs, and as a joint VT events together. And they also reported that up to 76% of the patients were free of any arrhythmias after the procedure. More importantly, they reported that they did not need to intubate and sedate or perform deep sedation in any of these 59 patients. And based on their results, they suggested that this procedure can be used or may be used preventively to prevent intubation of the patients, whereas the previous report before that used the procedure more as a bailout or in addition to sedation and intubation. More recently, there was published a multicentric study from Italy, which included 184 procedures performed in 131 patients in 19 centers, although most of the procedures were performed in 2 of the centers. In this series, only 26% of the patients underwent VT ablation, and only 20% of them were intubated. On the other hand, 8% of the patients had a refractory cardiac arrest, interestingly. What is also interesting about this registry is that more than half of the procedures were performed without any ultrasound guidance, only based on anatomic landmarks, which is by some pain management physicians consider as an obsolete method. Nevertheless, they observed only one major complication. They reported ATPs and shocks together as one outcome, and they reported that 92% of the patients had reduction of ATPs or shocks more than 50% from the baseline for 12 hours. And they did not see a difference in the effect with regard to whether it was performed by high volume or low volume center, whether it was done by just a single bolus or by continuous infusion, or whether it was performed by anatomic guidance or ultrasound guidance. Overall, they reported a reduction of ATPs or shocks by 100% as a median. Also, interestingly, for this study, they developed a 3D printed model of the neck and developed a formal education program for other centers to learn this procedure. Most recently, published data come from a joint effort of our center together with the Duke Heart Center. We collected together 117 patients. 68 came from ICAM and 49 from the Duke Heart Center. 56 of the patients underwent VT ablation. 56% were intubated. 18% had a bilateral blockade. And we also have shown that after the procedure for 24 to 48 hours, the burden of VT episodes and separately also ICD shocks reduced significantly. And up to 63% of the patients had the decrease of VT episodes more than 50% for next 24 hours. We did not observe any major complication, and there were only 2 minor complications. We also tried to analyze some predictors of the efficacy of the procedure. Nevertheless, we did not find any predictor such as age, etiology, whether the patient was intubated or not, and others. So in ICAM, we have so far performed 83 stellate ganglion blockades for electric storms. And it was really a true electric storm with many episodes. We perform the procedure by ultrasound navigation. We use a lateral approach. In most patients, we use only unilateral approach. Only in few patients with a failed procedure and continuous VT arrhythmias, we perform also bilateral. It is in our center performed by ICU cardiologists trained in this procedure. And compared to the other reports, 89% of our patients underwent VT ablation, and it was performed as a part of management of the patient before the ablation, just to survive over the night or over the weekend, or sometimes after failed ablation to be able to extubate the patient and manage the patient conservatively. Based on the definition, various definitions, we can say that 61 to 65% of our patients have clinically meaningful reduction of VT burden, either as a reduction by more than 50%, or that they had before the procedure ICD shocks, and after the procedure only some ATPs, but wasn't shocks anymore. And what I found very useful also for someone who would like to pick up this procedure is that in parallel we also have a program of stellate ganglion blockade for refractory angina pectoris. And this is really a nice clinical situation to prove that you are doing the procedure very well, because most of the patients are very symptomatic. You do only this one procedure, nothing else. and most of the patients develop Horner syndrome, and most of the patients decrease the symptom, which we can often document even by bicycle ergometry, that you can see ischemic changes and the patient doesn't feel any pain. So it gives some reassurance to the operator that the procedure is done well, which this reassurance you don't have in some critical ill patients. Overall, from these 83 procedures, we had only 2 minor complications. However, we saw one death, which occurred in a patient with a terminal heart failure who had repeated ablations, was receiving multiple antiarrhythmic medications, and 2 hours after the block procedure, he had asystole. And the autopsy didn't show any structural complications, so we concluded that there was a time relationship, but probably not, or hopefully not causal relation to this procedure. There is an ongoing randomized study because all the current evidence comes from observational studies. If anyone would be interested to join the study, just drop me email. So far, we have randomized to placebo procedure, sham procedure, versus real, or hopefully real, stellate ganglion blockade in 46 patients. We are planning to include altogether 180 patients. So the results will be available in 3 to 4 years. I know of some other also studies being planned or even conducted in other countries. So in conclusion, stellate ganglion blockade is safe and feasible bedside procedure, which is already done in many centers. So far, we have only observational evidence, but the evidence is promising, and it shows hopefully efficacy of this procedure. There's at least one randomized trial ongoing. And given the documented safety of the procedure, in contrast to the condition in which we often see the patients, life-threatening electric storm, critically ill patients. So I believe that this procedure could be done safely as a complementary part or as a bailout to the standard management of electric storm, until the randomized studies will show otherwise. And thank you for your attention.
Thank you very much. I would have maybe one comment. Maybe you can mention how long does it last, this procedure, in terms of the effect, not the procedure itself, but the effect after the procedure. We know the data from these ischemic patients, how long this elevates the pain after the procedure for them, the ischemic pain.
Well, this is an interesting question, and there's no clear answer. The anesthetic effect of the anesthetic agent should last 1 to 2 hours, but it is thought that there happens some kind of neural reprogramming, and this is known from the pain management or chest pain management, where the effect of the procedure lasts for 7 to 14 days, usually 7 days. But what we observed from our experience in the effect on electric or ventricular tachycardia lasts like 1 to 2 days. And what we saw in our patients is also some kind of blanking period effect, which may take some 2 to 3 hours. That after the procedure, you can still see some shocks for 2 to 3 hours, and after that, you can see like major reduction of the events. But often, together with the procedures, we perform also other standard procedures, like we give additional medication. Sometimes the patient is intubated, and so it's difficult to differentiate it in a randomized, non-randomized setting.
Okay, thank you. Any other questions, comments? Yeah, please.
Thank you very much. From your experience, if you go for the unilateral approach, does it matter which side? And And the second question, the Horner's syndrome, is it must-have? So you shouldn't expect any effect without?
By default, we perform left-sided ganglion stellate blockade. There are some centers who do it also bilaterally. And this experience comes from the pain management of angina pectoris, because there are more bundles leading from the left side. And to the second question, the hoarseness or like a paralysis of the vocal cord is a temporary complication which can last 1 to 2 days. But we observe it in our series only in 2 patients. So it's not very, very common. And it's not anything serious to be worried.
If you need to have Horner syndrome for it to be effective.
Not the voice hoarseness. The Horner syndrome, that's also interesting. In our series and also in the larger series from Italy, they observed Horner syndrome only in 40 to 50% of the patients, also in our patients. And we see the less frequently in intubated and deeply sedated patients. Whereas in patients managed who come for ambulatory treatment of angina, 95% or even more of them develop Horner syndrome. But there was never any association found between the development of Horner syndrome and the effect for arrhythmias. On the other hand, back to angina pectoris, in few cases who don't develop Horner syndrome, usually also they don't have also suppression of the chest pain. So development of Horner syndrome probably does not predict efficacy, but absence might tell you something that you just applied the medication somewhere else, for example.
Okay, we have to move on. So thank you very much.
Thank you.
And I will turn the chairing to Fermin.
Thank you. It's my honor to introduce Dr. Kausner, who will discuss complications of VT ablations, and more importantly, how to minimize them.
Okay, so I think it's important not only to talk about success and efficacy, efficiency, but also about complications. And we are now analyzing a large cohort of patients, so I will share some data, but also some data from literature. And we published this paper a long time ago, 10 years ago, and that was our first analysis of complications. And you can see that in idiopathic VT or VPB, the complication rate is substantially lower on the level of complications, so you can expect in SVT ablation compared to structural heart disease, where you have about 8% in a large volume center. We did not have any mortality at that time, but there were mostly vascular complications, but we had also some perforations and thromboembolic events. Very similar data were published from a group of Bill Stevenson from Boston. You see structural heart disease 6%. They also analyzed idiopathic, which was on the same level like our study. And from Milan, from Della Bella Center, you see also very similar complication rate. And they had higher rate of tamponades compared to us, but they don't use intracardiac echo routinely, so I think that's one explanation, in my opinion. But otherwise, very similar data. If you look at some multi-center trials, like this Thermocool trial, there was some peri-procedural mortality, because the more centers you involve, less high-volume centers, maybe you can expect also higher complication rate. And but again, these serious complications were on the level of about 7%, and vascular complications again leading. Interestingly, if you look at prophylactic ablation studies, we have several, but these are three mainly quoted. It looks that the risk is lower, but if you look at the last one, which was published lately, SMS study, it doesn't seem to be the case, because there was 9% of complications, and some of them quite serious, I would say, like tamponates. If you look at the data from large databases like this US patient care database, it seems that it's not decreasing the number of complications, and let's say the rate is even higher. But again, there might be multiple reasons, but also inaccuracy in sampling of these data. You can see that in hospital mortality could be about 2%, which was also the case in these single center studies, because we are dealing with very sick population of patients. So if you look at what might be predictors, of course, the volume matters. This has been shown for AF ablation as well as for VT ablation, as you can see here. And if you do, the more you do, the lower complication rate you can expect. There are some attempts to analyze large cohorts of patients. This is from Germany, a recent study, 1,900 plus ablations. And they analyzed both without structural heart disease and with structural heart disease. So you see that the minority was, or less than half, were in structural heart disease. And they came out with this modified RIVA score, which takes into consideration age and NIHA class, structural heart disease presence, or epicardial puncture and glomerular filtration rate. And depending on a value of points, you can predict risk of complications. So this is our preliminary analysis, more than 2,200 ablation procedures, 655 for idiopathic, majority for structural, and of course complications were again more frequent in structural, but 6.8% compared to 4%. And if you look at non-vascular complications, it's interesting that the rate of tamponade or perforation, because we practically never, with the guidance of intracardiac echo, you never have tamponade during the procedure, because you always see accumulation of blood and you do drainage before the patient has developed hypotension. So it was more or less around 1% in both groups of patients. Interestingly, in some of these idiopathic, we saw POP, and after POP there was this perforation. And there is one study showing that POP probably might be the reason of many of these complications. Hemodynamic deterioration, there will be a debate later on, so I don't want to talk about, but we had only in less than 1% in this cohort of patients. And major vascular complications were most frequent. We see that again, they were higher in structural heart disease compared to idiopathic, but there was difference in terms of representation of gender. In structural, there were more frequent complications vascular in females compared to idiopathic, where there was male predominance, but we can explain it by more frequent left-sided procedures in males in idiopathic setting, because they more often had summit arrhythmias or arrhythmias coming from cusp, so a more frequent arterial access for retrograde approach. And we try to calculate or develop some composite risk score for major vascular complications in the whole cohort of patients, including these idiopathic cases. And this is based on multivariate regression model, and then age, female gender, and serum creatinine creates this score, and the higher score, the higher risk of major vascular complications. Epicardial access probably increases by definition the risk because you do additional instrumentation, and there are complications related to the access or related to mapping and ablation. You can tear ventricle, for instance, if you have adhesions. You can create pericarditis or some arrhythmias. So this is a summary of earlier studies. You see that the major complications could be again around 8%. In many series there were tamponates described, and there were also some deaths even in small cohort of patients. Today, there is, as you know, there is an approach with the insufflation of CO2, and there are some observational studies, very small series so far published. It looks that you can avoid perforation, but there is a bleeding again in some of these series, about 4% of serious bleeding. So nothing is absolutely safe, but you have to be probably cautious. This is analysis which Peter did a couple of years ago. At that time, we had more than 100 punctures, and we had some curious complication like puncture of colon, but nothing happened. We just had a nice picture of obstructions in the colon, but no sequelae. And we had one severe pericarditis and delayed hemopericardium in 3 patients. So we believe that the way how we do it is reasonably safe. So how to avoid complications? There is the whole list of things what you can do. I will touch just briefly some of them. You should know what is your complication rate. I think every center which does these interventions should follow complications. We should develop some system how to track complications, because if you only sit at the end of year and say, who remembers any complication, then you definitely underestimate significantly. So we analyze in our center every year all interventional procedures and all complications which prolong hospitalization, require any correction. And we have 3 categories of complications. Life-threatening complications are around 1%, and we analyze all of them, and we do some corrective action if there is some excess of any complications. You should be prepared, of course, because I worked in many centers, and if you ask, do you have a pericardial needle? They say, well, probably not. And you should have this set which you open only if you have tamponade, and nobody needs to run around the lab and look for a needle and look for some tubing, and etc. Operational standards. There was a lecture of Tom de Potter, how you can minimize complications and speed up the procedure by use of ultrasound. We analyzed again a large cohort of more than 4,000 patients, and you see that the complication rate was significantly lower when you use ultrasound, especially surgical complications. Online imaging, we had very nice lectures. You not only see the substrate and contact, but you can also see what you are doing, especially for transeptal puncture. But not only for transeptal puncture, you saw some cases of thrombi on the catheter. But you can see also how pop looks like. Then you can create really, it's a blast. And you can tear the tissue, and this on the right panel you see experimental pop, and you see the crater it creates. So if somebody believes that to have a lot of pops is a good sign of efficacy, it's also very high risk. You can use imaging together with electroanatomical mapping, CT or MRI. We also heard some talk about that. Some people believe that contact force improves safety. There is no single study showing that contact force really improves safety. But just, by the way, this is first ever made map of the left ventricle with contact force technology, Smart Touch. That was from our study. And aggressive anticoagulation, I would like to remind you that it was, again, intracardiac echo. And this is the first study from UPenn showing that with conventionally accepted many years ago ACT 250, you can have, in about 10% of cases, you can have thrombi on the catheter or on other tools, on wire, etc. So you have to really increase anticoagulation rate until 350, which is more or less current standard. But there was mainly intracardiac echo, which again gave us this feedback, and we started to aggressively anticoagulate. Maybe new technologies like pulse field can do a good job. This is one of our cases which Peter did, and you see here the sphere 9 catheter epicardially, and you can do epicardial ablation even if you are close to coronaries, maybe that would increase safety. So in conclusion, ladies and gentlemen, we have to be cautious. We have to follow the rate of complications, analyze them, and obviously in structural heart disease, VT, the complication rate is much higher, also in epicardial access, and we should use all measures to decrease complication rate. Thank you very much for your attention.
Any questions for Dr. Kausner? I have a point of view. I think frequently we are asked if retrograde or transeptal it's better, if retrograde increases the risk of embolic events or not. What is your point of view regarding this?
Yeah, we have one study where we measured S100B protein, and in retrograde was higher than in transeptal. But generally, I liked retrograde for some locations of the substrate, like perimitral, for instance, or in aortomitral continuity, etc. We decide in every patient individually. Also, if the patient is older with peripheral disease, with a high probability having some plaques in aorta or calcified aorta, we always do transeptal now. Probably transeptal is now prevailing, but I still like for some indications to go retrogradely because first I'm used to it because I did all former accessory pathways on left side more or less retrogradely. And second, really for some locations of the substrate or focus, it's better, but sometimes you have to use both. So I think it should be individualized decision.
Okay.
Thank you very much for this.
I didn't pay him, you know. But it's nice to have somebody who always asks.
Yeah, it's really excellent overview of all possible complications. And I have one specific question regarding the prevention of steam pops. So when you were in our lab teaching us VT ablation, so I remember you used like 30 watts, 40 watts maximum, not more. What is your settings now? And
we are not very far from it because when you use, well, you can use now Q-dot or diamond temp with 50 watts, and it seems to be very safe, preventing steam pop. But if you use conventional catheter, and often you have steam pops with 30 watts or 35 watts, depends on what is location, what is flow around, etc. But with conventional, we rarely go above 40, 45 degrees, watts, because you can see very frequently pops, and you can, when you see this whitening, sudden whitening, it's like boiling already tissue, so you can stop application. But the problem is that sometimes you have pop and you have no whitening, you have no rise of temperature or or impedance, or if you have drop of impedance, it's also predicting to some extent pop, but there is nothing which is really 100% perfect to predict pop formation. But I believe that especially if you are working in a relatively healthy myocardium, like in idiopathic, like in papillary muscle base, you should avoid pop because it can really, the blast can tear the tissue and you can have perforation.
I think it's important what you said regarding this. I think it's in each catheter is different. You can get a stim cup with 35 watts with one catheter versus 40 with another catheter. So I don't think there is one setting for all. I think you need to be familiar with the catheter you're using because I've seen differences on duration and power to cause a stim pop. And I also think one important thing about eyes is somehow, if you're watching constantly your application, you can see how the tissue starts to boil before it explodes. So I stop when I start seeing that, usually if it's prolonged or higher power.
And sometimes there are bubbles also going outside. So you see, you can predict, but it's not perfect.
Yeah, it's not perfect.
Just one comment on that about the different catheters. There are data, there were also different generators can provide a little bit different outputs, different impedance. For example, old Stocker generator, if somebody's using still that, it kind of some impedances, it gets much more power into the tissue than the other ones. So just be sure that you use what you used to be, what you use in your lab, that you something that you do not cross what other people do, or just copy what other people do, but may not work in your place.
Okay. Thank you, Dr. Kaufman. Our last speaker on the session is Gian Battista, who is going to talk to us about a little bit of a change. We're going to pulse field ablation in atrial fibrillation. Is it a game changer?
So while they find my presentation, as it's a bit on the long side, I would like to thank the organizing committee for giving me the possibility to be here. Professor Kaustner, Dr. Garcia, Dr. Peichel for moderating. Now, when I was asked to give this presentation, I thought, well, the obvious answer would be in one slide. Obviously, it is a game changer. But why? And can we get better results with it? So do I need to talk with this, or this works also? Okay, I'll talk with this. Okay, now we know that catheter-based ablation is the most effective treatment for atrial fibrillation. We know this, and historically and traditionally has been performed with thermal energy sources such as cryoenergy and radiofrequency ablation. We know perfectly how, I mean, I don't need to walk you through this, but you know that there are two main approaches that have been used, which is a single-shot cryoballoon ablation and the more traditional, but with a lot of evidence, point-by-point ablation with irrigated radiofrequency. These are data from the Fire and Ice. Now, what are the limitations of these thermal energies? Actually, the lesion durability and the collateral damage to adjacent tissues. What about lesion durability? Now, although we as the EPs, we're very happy when we get these beautiful isolations at the end of the procedure, we have to always bear in mind that many of these veins will reconnect, such as you see here, again, Fire and Ice by Karl-Heinz, showing that up to two veins per patient were reconnected during redo procedures. Of course, it's a bias because these patients exhibit, again, atrial fibrillation, so they're more likely to have reconnected veins. But even at redo procedures in patients who have not experienced procedures, we still see with these kind of energies reconnection. This is also shown outside of the veins. If you address typically persistent atrial fibrillation, what you will see is that typically coronary sinus, LAA appendage, this is data coming from the from the Austin group will reconnect in a significant amount of patients. Another limitation is, and this is for me the reason why we have nearly completely shifted to PFA in our lab, is collateral damage to adjacent tissues. We have to realize that atrial fibrillation is often an elective procedure, if not always. Atrial fibrillation ablation, it rarely leads to consequences such as death. So we have to be sure that we're treating the patient with the safest technology we have in our hands, especially with the numbers that we are treating. And of course, the dreaded atrioesophageal fistula, which has first been described a few years ago, and thanks God is extremely rare, will lead, unfortunately, to a certain amount of near deaths. So we're talking about 85 to 90% of patients will die or will remain neurologically impaired. But you also have PV stenosis, which we don't talk about anymore because now we're ablating outside of the veins. And of course, phrenic nerve injury. Although phrenic nerve injury is often transitory, I can assure you, coming from a big cryoballoon lab, that it happens occasionally that these patients still persist and they're extremely impaired by this complication. Just a slide on atrioesophageal fistula. So this is why, at least in our lab, but I was given to talk about an opinion also based obviously on literature, but pulse field ablation is coming in as a huge horse in all around the world, and certainly at least in European labs it's been increasingly used because it's safe and it offers extremely good results. So what is pulse field ablation? As we know, it's electrical fields that are applied to the cardiac tissue, leading to disruption of the membrane integrity. Okay, so there are various devices that can deliver PFA. These are just a couple of them. The Affera catheter, which we will see a short video later on, the Farapulse catheter. You have other devices. Every company is working on developing its own PFA device because it's really groundbreaking technology. It's easier to do these procedures and certainly safer, as I said. Now, lesion durability. Okay, we can discuss about that. Lesion durability has been. We have to realize that this is a very new technology in the EP lab. I know it's not a new technology per se, but it's a new technology in the AFib ablation world. And lesion durability. So we're a bit unfair by comparing what is lesion durability today, because we have a certain amount of a very small amount of experience compared to radiofrequency and cryo. But anyway. What we have seen, and this is a study by Dr. Reddy showing the results of the Impulse PEFCAT and PEFCAT2, showing that basically if we start optimizing, and we are in the process of doing this with every new device that we are getting on the market, if we do optimize the way that PFA is given, then what will happen is we will have more durable pulmonary vein isolation. This is a propensity score match comparison between cryo, PFA, Farapulse, and radiofrequency for paroxysmal atrial fibrillation in our lab. And what we saw is that at redo procedures, PFA was actually the group in which we had less reconnections of veins. Excuse me. Collateral damage to adjacent tissues, I will not eternize myself on this. It does not or creates minimal lesion to adjacent tissues. These are direct applications of energy on the esophageal tissue, directly showing that RF energy creates ulcers, creates damage. PFA does not create anything. This is the histological cut of that esophagus. Of course, it's experimental. The Advent randomized trial has shown that basically the outcomes are similar, or at least non-inferior to thermal energy, and that safety, if with experience mounting up, is gradually getting better and better, with very, very few procedure, or actually energy-related complications, as you can see here from the manifest. This is a study that I found fantastic, because this was actually ideated by one of our fellows, showing how easy it is to get, if you're a cryballoon user or let's say, yes, or a single shot user, let's put it this way, how easy it is to transition from this single shot procedure to PFA procedures. Again, this is only regarding Farapul. So the versatility of these catheters and of the energy source made it very easy for new users to adopt it in a very, very consistent and efficient way. What about our experience? So this is more or less what we do. We are lucky. In Brussels, we have basically all the commercial devices, or at least most of the commercial PFA devices out there, with more than 1,000 cases with Farapulse. Galaxy, we're not using it anymore, but 90 cases with Affera, and that's, according to us, if we could all do them with Affera, this I agree is an opinion, we would probably all do them with Affera because it really offers the best of not both worlds, but every world, as I will show you later on. The Affera, the Sphere 9 catheter, probably you have all seen it. It's a lattice tip catheter that can deliver PFA and irrigated radiofrequency, which permits you to ablate safely on the posterior wall with PFA, and if you wish, you can on the anterior wall or on the mitral isthmus go with radiofrequency and reach a very deep lesion. This is what it looks like. Our experience again, 89 patients. We mainly dedicated to patients who have non-paroxysmal AF because we mainly perform PVI in paroxysmal AF and nothing more. So these are mainly patients with long-standing persistent AF or repeat procedures because this catheter can map the arrhythmia. It can ablate with both energies, as I've just told you. Very easy to complete PVI, very easy to complete CTI. CTI is completed in our lab at least with radiofrequency. Anterior mitral line also, posterior mitral line. It's extremely consistent, extremely fast, and Affera users will absolutely tell you that this is the experience that is widely seen with this catheter around. So this is a short video of what it looks like. 45 seconds, you will permit me. So you see the catheter going on. Obviously, it's sped up. Although we're not that slow, but as fast as this is. So you can easily create your LA map in a very short time. It's really extremely consistent with the anatomy. It's extremely fast to depict the four pulmonary veins. You can create, obviously, while you are mapping, you can create a substrate map. You can really use it. It's an extremely versatile system. And this is what it looks like when you ablate. So we're here on the posterior wall. We're obviously ablating with PFA. You see these huge circles around. It's a let's say large point-by-point ablation, and then you can check your isolation without the need of another catheter. So it's a really all-in-one. It's the best of all worlds. Okay, so just a small. These are my last slides. I strongly believe that today we do have methods, and we have matured the experience to perform safely PVI also with thermal energy. But I believe that in the field of persistent AF, PFA permits us to be more audacious, bolder, let's say, in getting outside of the PVs and ablating substrate, being in a way feeling safer than you would with the thermal energy. So this is how we approach long-standing persistence in Brussels. Again, we do not have as many Affera catheters. There's a shortage of production at the moment. But we do perform with PFA solely these kind of patients. These are patients who are exhibiting long-standing persistent AF or persistent AF. And we start by performing a pulmonary vein, an antral pulmonary vein lesion, a posterior wall isolation, and an anterior roof line. We then, stage 2, if the patient goes into an atrial tachycardia, we map the atrial tachycardia, of course, with a mapping system and with entrainment maneuvers from the splines. But usually we go to stage 2, so we continue ablating the electrograms, as you can clearly see now. You see the map on the right side. These are very extensive maps. This is matter of discussions, but we do have excellent results comparing to what we would have with our previous methods. And we feel safe by just going around with the PFA. The question would be, what is the function of these atria? This is a question that could be obviously coming out, but again, these patients had no function since probably a long time because of persistent AF. Anyway, you can clearly see patients going into, this is an example of patient going into an ATAC, entrainment maneuvers, and then ablation with conversion to sinus rhythm. And these are our results. But this, again, is a single-center, non-randomized study based on roughly, now we should have reached 150 patients. We see that the freedom from any arrhythmia is around 80%. Freedom from AF is good, more than 90%. And as you can see, and as you can clearly see on the low right panel, what you would imagine is the longer the patient has been in AF, the lower the results will be, obviously. So if the patient has been persisting for a longer time, you would expect a lower result even with the approach. This is a small slide showing the vault. This is anecdotal. We were included in the first-in-man. This is a PFA balloon that has been designed for PVI only. This balloon actually has struts mounted on a balloon that you expand against the wall of the PV. It can map, although during the first-in-man we had to map with an HT grid. It can map, it can pace, and it can certainly ablate, as you can see here immediately, the high-frequency potential disappearing and the patient going into sinus rhythm. Technology, I'm going to the end of my talk. Technology-specific complications, coronary spasm. This has created a lot of fright at the beginning of the utilization. This is a paper published by one of our staff members, Domenico Della Rocca, showing clearly that during ablation near a coronary artery, this is what could happen. It was absolutely awful. I was in the lab at that time. So we decided whenever we go near a coronary artery, anatomically, we do inject nitrates, and we have seen that it's extremely efficient in preventing these kinds of reactions, certainly in preventing ischemia. This has recently been published in Circulation Arrhythmia and Electrophysiology. Just to show you these are my last two slides. So AF ablation in the elderly. I would like you just to look at the third line. We actually looked at the two cohorts of patients, of elderly patients, and as you can see in the cryo group, and not surprisingly, most patients were paroxysmal AF. Whereas in the PFA group, seeing the fact that we do ablate outside of the veins, a lower percentage of these patients were in PAF, and this was significantly, in paroxysmal atrial fibrillation, this was significantly different. But if you look at it, the fact of ablating outside of the PVs permitted exactly the same result in these patients. Again, it is a single-center study, so should be randomized, I do agree, but it does give a hint of the fact that with PFA you can probably cure, or at least say, keep more patients outside of recurrence of AF, even with more advanced stages of the disease. We know the stiff left atrial syndrome that has been published with radiofrequency. This was again, a study was published in association with the Austin Group and us, showing that basically that PFA does not worsen baseline pulmonary hypertension in patients that had previously underwent radiofrequency ablation. So in my conclusion, the adoption of PFA energy sources has the potential to significantly reduce procedural duration, according to what we're seeing, potentially improve lesion durability if studied, and we have to be careful because every device is giving PFA in a different way. So it will have to be analyzed with all different devices coming on the market. Prevent the risk of collateral tissue. I think this is damage. I think this is a no-goer. And maybe, well, at least this is what we're preliminary seeing, but of course it should be studied in a randomized way, improve the success rate of non-paroxysmal AF ablation. I thank you for your attention.
Any questions?
Hi. Thank you so much. It was a great talk. Mansoor Azmini, Chicago. Just one question about Sphere 9. Looks like when I looked at it in vitro, one lesion either with RF or with PFA is about 18 millimeter, which is great. Even 2 seconds of RF looks like it does 18 millimeter. So I noticed that on your map, you had quite a few lesions in the posterior wall, which as if we are doing a regular 5 millimeter. Do you think we were overdoing the overlap, or should we just do few and with a little bit of overlap with that? Thank you.
It's a very good question. It's very difficult to go in and see. This is what we have been advised to do, to overlap as max as possible. This is our first experience, so we don't know what it will be in the future. But for sure, patients two out of these 90 patients have come back, and all 4 veins were completely isolated antrally. But that's a very good question. Thank you.
Any other questions?
Any more questions?
Yes, one from that side.
So, maybe I will have one comment about the persistent AF and Sphere 9 ablation. There will be a publication of the late breaker at the HRS comparing a really large trial, 480 patients, which were randomized 1-to-1 between cardio and the Sphere 9 for persistent AF ablation. So hopefully we will see the difference there. I really hope. I don't know the results. But I mean, it makes sense in a way because this is a large footprint catheter, and for persistent, for large atria, like if you have a left atrium of 6 centimeters, just go with 4 millimeter tip. It's just very difficult to do. I mean, if you have at least something bigger to really make a reasonable durability among the linear lesions or whatever is the strategy you have. Usually there are some linear lesions in there. So it makes sense that this should work, and I hope for the results. So in 1 month we will know the results in the very large FDA-approved trial.
And I think that we are also daring more. This makes a lot of difference. When you're on the posterior wall and you're practically sure that you're not damaging anything, it makes you maybe do more, too much, but certainly, I think this is a part of the success that we're having.
So one more comment. Recently there was ERA conference, and there was a lot of AF and a lot of pulse field for AF, and as a topic, obviously, but I'm enthusiastic for pulse field. But there was a lot of people that are really reluctant, they are not believers into the technology. And there was one comment after the conference that it was a nice conference, but it's too much pulse field. So I don't know whether this is, what do you say? Some people say it's too expensive, but this is just now, but in 3 to 5 years from now, there will be a lot of different tools to do it. Maybe the spasm is always coming up, maybe there is some other thing. So what we should do just to convince people we are right and they're not really experienced yet, or what do you feel we need to
I think it's a game changer. We should tell them it's a game changer. No, yes, I completely agree with you. I think it's, well, like every new technology, there is a bit of reluctance. I think it's been put on the market as a uniform. I know that Joseph has his opinion on it, and I think it should be studied more in detail, how we have to give it for which device, It makes a huge difference, really. I think you cannot uniform, it's like saying, I really don't, like I don't know what but it's like putting everything in the same box. I think PFA is much wider than we think it is. I think the way that it is given with Farapulse has been, if you look from the monophasic to the optimized biphasic, we have a twofold permanency of PVI. So that means that it has to be studied a bit more, and maybe Peter has been put on the market, you know, like, but it's not only one type. It's
I know that we are over time, right? So one last comment, actually, you mentioned very nicely the spasm is like issue, and everything is like solved, right? So first of all, when we started with pulse field, we have a lot of troubles with asystole, okay? Bradycardia, asystole. When atropine came, okay, it's solved, okay? Now, spasm, okay? When spasm happen? On the CTI. Every single time you are with pentaspline catheter on CTI, always spasm. 99% of the spasms are asymptomatic or subclinical. Fine, we have now nitrates. So we solve it properly. So we publish nitrates, get only single one mild spasm, okay, after nitrates, after IV nitrates. Now hemolysis. We know that number of application and or non-optimal contact cause hemolysis. So we need to deal with. It's always normal. But actually the criticism about pulse field is practically, no issue.
I agree with you, and contact is.
And we need to study. For sure, it's so new technology, so we need to still study. We are here for study, right?
Based on what you said, the Volt does not give. We analyzed, and there is absolutely no hemolysis because you have contact, because it's sticking there.
Yeah.
And for the pauses, we resolve it differently than atropine. So we start ablating on the right side. Because if you ablate on the right side, you excite the ganglion long enough, and you will never have, because pauses only occur on the left side.
And then it's always issue about volumetric lesion, because now for a lot of technologies it's volumetric lesion, not targeted lesion. Okay, fine. I think I'm finished. Okay, thanks.
Thank you.